We have a very interesting case here. We have a lady who attended just this morning with otitis externa. So otitis externa is an inflammation stroke infection of the outer ear canal. And she had occluding dead keratin, dead skin, and debris. She normally visits an ENT surgeon at the hospital. She normally gets this occlusion removed by the NHS. However, due to the backlog, she decided to attend privately. She'd been instilling sodium bicarbonate earwax drops for 3 days, twice a day for 3 days. With dead keratin, sodium bicarbonate drops, I feel, works best. Generally, I do recommend olive oil drops if it's earwax, but sodium bicarbonate just has this effect on skin. It just really loosens it. And you can see here this is the patient's left ear we're starting off with. You can see it's fully occluded with debris, dead skin. It's turned a bit mushy because sodium bicarbonate drops can also change the consistency of the dead skin. You'll see when I enter the ear canal is slightly inflamed. That's a hallmark of otitis externa, and it's slightly red. And you'll see once I've removed all the occlusion, there's quite a few dry skin flakes around the ear canal, which is very common with people with otitis externa. People with otitis externa often complain of itchiness and irritation in the ear. It's vitally important that they avoid water entering the ear. That advice actually applies to the general public. Even if you don't have any issues with your ears, we advise not to put anything in your ear. So nothing smaller than your elbow should go inside your ear, as the old saying goes. And you should avoid water. Water can be a perfect help bacteria create a perfect breeding ground within the ear canal. So it's dark, it's warm, and then if you've got a bit of water in there, it's moist. So water is a big no-no in the ear. And you can see I've removed the occlusion and we've just got some skin. This skin is located midpoint of the canal. And with otitis externa, I try and remove as much of the dead skin as possible. If you've been watching some of my previous videos, I did explain we only remove skin when there's a clinical need. Someone with otitis externa, there is a slight clinical need because the skin will just form again very quickly. And then if you've got layers upon layers of dead skin, that skin can get infected. That can lead to erosion of the bony part of the ear canal, benign osteotitis. It can also develop into otorrhea, which is a discharge, some ear pus within the ear canal. So I'm going to try and move as much as possible. We're not going to get every little strand of dead skin or debris from the ear canal. We'll be here for hours otherwise. And some skin isn't ready to be removed. So you'll see in the second ear, which was far more impacted, there was a bit of skin that I peeled all the way to the eardrum, and I was trying to release the last flake of that skin, but it just wasn't ready. It was just too attached to the canal wall, and that's fine. So we just want to remove all the superficial, loose, dead skin. You can see we're peeling some skin off the posterior superior canal wall. So posterior means the back part of the ear canal, the rear end, and superior means the top, so the roof. And just using a fine end for this, a fine end is much better for dead skin. If you use a standard Zollner suction probe when you're trying to peel skin, you can get what we call clarinetting. I'm sure if you've been watching my videos, you've heard me use that phrase before. Clarinetting is when dead skin gets trapped at the entrance of the suction probe, and it flaps viciously, and that emits a very loud, high-frequency squeal, which is not only deafening for myself doing the procedure, but obviously the patient, because we're in the ear. Loosen the majority of that dead keratin skin. We're just gently pulling it down off the canal wall, and see another piece there. And this is some debris on the anterior canal wall. So anterior means to the front, and inferior is the base, so that's the floor of the ear canal. So just some debris around the ear, just mopping up. So we're kind of just on the juncture of the cartilage and bony part of the ear canal there. The cartilage aspect of the ear canal the skin is about 1 millimeter thick. There's some fatty tissue there, so we can put a bit of pressure, but when we approach the bony part, which is the inner 2/3, it's a very thin, delicate layer of skin, approximately 0.1 millimeters, so it's 1/10 of the thickness of the skin that coats the outer part of the ear canal. So we do have to be very careful. We don't really want to be making contact with the bony part of the ear canal. It can be very uncomfortable to the patient. They experience quite often acute pain. So we've moved over to the right side. You can see this here is a lot more occluded. The skin is a bit more damp on this side. And I'm just playing a bit of tug of war here, just trying to extract this skin. So some of the skin is still attached to the ear canal wall, so it's a bit of a resistance. It's trying to fight against me. So I'm just wriggling this along the suction probe, and there we are. I've got a huge piece of dead keratin. There's a bit more there. So we're kind of that semi-occluding piece of dead keratin is kind of midpoint of the canal. And you can see there's a bit of a thick layer of skin here. So you will always notice when we peel skin laterally, so near the entrance, the skin is generally a lot thicker. And the further down we go towards the eardrum, the skin becomes thinner. Again, I'm just trying to loosen this from the floor of the ear canal. And so some people might ask the question, why don't you use forceps? But this skin is too damp. With forceps, you grip it and you'll just tear it into a little piece. So if the skin is really dry and crusty, which can happen, typically happens when someone's had an ear infection and they use some sort of ear drops or spray, something like gentamicin drops or neomycin drops. It causes the skin to crystallize and all the debris to crystallize. And it almost turns into a kind of a solid plastic consistency, and with that you can actually use forceps, grip onto it and extract it in one big piece. But this is just way too damp for crocodile forceps, and that comes with experience. So the more procedures you do, the more ears, cases you deal with, you kind of know what's best. Sometimes you get it wrong. You watch the videos back and, well, maybe I could have used that. And that's why I do generally enjoy watching my videos back from time to time, just to kind of evaluate. We all continue to learn, no matter how much of a specialist you are. It doesn't excuse all the YouTube and Google armchair experts, but yeah, kind of always consistently learn. I have a lot of colleagues within the audiology field that do contact me with their videos asking for advice, how they could do things differently, and that's continuous professional learning. So remove the occlusion's completely gone. You can see the tympanic membrane, the eardrum in the distance, and on the posterior quadrant, so the back part of the eardrum, you can see a white patch, and that white patch is tympanosclerosis. So it's a calcification. It's like a scar tissue. You could get that for a number of reasons. You can have it due to acoustic trauma. So the eardrum has taken a battering from loud sounds, and in response it can calcify. Could have been physical trauma, so an injury or blow to the head that ruptured the eardrum and then it's healed over. Could have been an infection, so a middle ear infection, glue ear, and that glue ear perforated the eardrum and then it healed afterwards. Could also be barotrauma. So barotrauma is kind of a sudden change in pressure. So people who scuba dive, for example, that pressure could have perforated the eardrum. So this is the skin that I was referring to when I was doing the first ear. So we're peeling it from the midpoint of the ear canal. You can see how thinner this layer of skin is compared to the skin on the outer aspect, the lateral part of the ear canal. We're just trying to peel it as much as we can, and we can't get all of it. It's not ready to come out. You can't peel skin that's strongly adhered to the canal wall. So just kind of almost these flakes, I don't want these to flap around, so I'm just trying to get these long tails of skin, just kind of separate it from the rest. And so we're very close to the eardrum now. That's the anterior recess. So near the eardrum at the front, there's a hidden cave, if you like to call it that, or a cravat. So we're just going to be careful in that region. As you can see, the otitis externa, it's kind of, you can see the swelling of the ear canal. It's slightly inflamed. I'm just mopping up near the entrance now. There we are, we have the final view of the tympanic membrane. That's that large piece of dead keratin debris that I removed from the right ear. You can see it's quite a big piece. I hope you enjoyed that video, guys. Hopefully I'll upload some new ones for the next few days. If you're watching on YouTube for the first time, please do subscribe. Select the bell icon to be notified as and when I upload new videos. Similarly, if you're watching on Facebook or Instagram, follow the page. Feel free to leave a comment and like the video. Take care, guys. Have a great evening. Bye.